Shall we?
Yes, sir. Yes.
Yeah, we will start. We will
Okay.
start.
Okay,
People who are joining, they will miss. Okay, let them join.
Okay, sir. Okay, sir. Good evening, everybody, and we are very happy to welcome you all for the COVID-19 and Kerala situation and challenges, the webinar organized by Kerala University of Health Sciences, and we are very fortunate to have our respected VC Mohanan sir and Dr. M.V. Pillai sir, and all the distinguished faculty members, and also Raj Mohan sir, Suma madam, and many other faculty members we can see, and many other delegates and participants are all joined. And so we will have a very fruitful session, I'm sure, and it is all the more interesting. And I welcome all the distinguished members, and I request Mohan Kundamal sir, our beloved Vice Chancellor, to start the session with the opening remarks.
Thank you, Dr. Chandni. Good morning, good afternoon, good evening to all the esteemed participants from various parts of the world. As the Vice Chancellor of Kerala University of Health Sciences, I'm extremely happy and proud to welcome you all to this international webinar on COVID-19, focusing on the state of Kerala. The first case of COVID-19 was reported in India 18 months ago on 30th January 2020 at the same place where Kerala University of Health Sciences is situated, Thrissur, Kerala. A Keralite student who returned from Wuhan, China. After that, the whole world suffered different waves of the infection. Kerala could control the first wave remarkably well. We are in the midst of the second wave and it is getting prolonged with no signs of reduction. Immediately after the first case, on January 2020, we conducted an international seminar on COVID-19, and that generated a lot of knowledge, and it helped the state of Kerala in tackling the disease. After that, we have conducted several webinars on various aspects of COVID-19. This 5-day webinar starting today is organized with a definite purpose of generating latest knowledge as well as to seek avenues for research. University intends to collaborate with various agencies and universities around the globe. We want to introduce our young researchers to the world leaders of virology who are with us in the next 5 days. The webinar became possible because of the unstinted support and help from Dr. Shyam Kutilil, Professor, Institute of Virology, Maryland University, USA, and Dr. M.V. Pillai, Global Virus Network Advisor from Jefferson University. Both of them are great supporters of this university. We are so happy that Dr. M.V. Pillai is talking on Global Virus Network and how it can help us in tackling this situation. Dr. Gabriel Gonzalez is a world-renowned virology researcher from University of Dublin, Ireland, and he is speaking on COVID-19 variants and its impact. From Kerala side, we have our experts, Professor Chandni, who is moderating, and Dr. Vinod Skaria, who is the principal scientist, CSIR of New Delhi, Dr. Sharada Devi, Professor of Microbiology, and Dr. Sri Kumar, scientist from Rajiv Gandhi Center from Trivandrum. So with these few words, I request Chandni to start the proceedings. Thank you.
We are so fortunate today to have with us Professor M.V. Pillai, and sir is always so keen to the various academic developments and academic research minds in all the people and those who are working in university, And all the sessions when sir is there, it's always so much enthusiastic and motivating to all those who are attending. And today we are really very, very fortunate to have sir with us. He's the Senior Advisor, Global Virus Network, Thomas Jefferson University, USA. And in fact, sir needs no introduction to this audience today, but I welcome sir to deliver the initial and inaugural session of this 5-day webinar. Over to you, sir. Welcome to the conference. Thank you for being with us today. Thank you, sir.
Thank you, Chandni, and Dr. Mohan, the most dynamic Vice Chancellor of the Kerala University of Health Sciences, who has started a trend of excellence. Congratulations. And his associates and his supporters, his well-wishers. Because of the time constraint, I'm going to be focusing on some highlights of the Global Virus Network and also on the Institute of Advanced Virology, which is coming up in Thomakel. Searching for my screen sharing. It's not coming. Please share my link. Harlal?
May I help you, sir?
Yeah, Hilal, you can share.
Yeah, please go on and in the screen sharing. Okay.
Are you able to see, sir?
Yeah, I can see. All right. This may be the best day to have a session like this on the confluence of technologies and the confluence of think tanks and great leadership in Kerala. We just concluded the Tokyo Olympics. If there is one message that we can take home from Tokyo, it's the fact that in spite of 200 million confirmed to have COVID around the world, and a lot of objection, opposition, demonstration, and criticism against the Tokyo Olympics, the organizers did a wonderful job with the minimum disturbance. And here we are, the world's greatest democracy, United States, comes up on top with 39 gold medals. And the world's largest democracy, India, for the first time is coming up with a gold medal in track and athletic events. And this track and athletic events is very, very significant and symbolic of where we are heading. India has arrived. It's not like winning hockey, gold medal, or cricket leadership. We are now entering the world arena of universal participation in athletic and track events. You couldn't have picked up a better day than this to celebrate the Association of Kerala University of Health Sciences with the emerging technological prowess of India. Congratulations. Congratulations to Dr. Mohan and to the IAV leadership, the government of Kerala, and the state governor, Sri Arif Muhammad Khan. He is the chancellor of our university, and the chief minister, Sri Pinarayi Vijayan. Both these leaders have amazed me for their scientific bent of mind. They understand science. And this is a great opportunity for Kerala University of Health Sciences to serve as the bridge and as a cementing force of so many top-class institutions in our state and in our country, so far working in silos with no crosstalk. If we pull our resources together, the next gold medal in athletics and track events may come back to India, and along with that, you may be placing Kerala and India in the world map of scientific excellence in medical research. Next slide, please. Headline. Let me see if I can. This quotation is by the world famous philosopher George Santayana. Those who forget their history are condemned to repeat it. The gist or the essence of this quotation I will be explaining in the next few slides. Next slide. This is the global virus network distributed around the world, and I will be coming back to this topic very soon. This is the emblem of the global virus network, established by two eminent virologists of repute, Robert C. Gallo and Dr. William Hall. And fortunately, both these people have come to Kerala many times and were associated with the establishment of the Institute of Advanced Virology in Kerala from its very beginning. Next slide. Next slide, Tharlal. This international global virus network is actually a next. Go back, please. Go back to the definition, please. Next one. Okay. This is an international coalition. Can you go back? Tharlal?
Which slide, sir?
Yeah,
Okay, yeah, right. Yeah. In the previous one, the next one.
This one, huh?
Next.
The previous one.
Yeah,
This
one.
is an international coalition of medical virologists. Can you go back to it, please? Go back, please. Go back.
So this is the first slide.
Yeah,
This
the
one,
next
second.
one. Next one. No, the previous one.
Oh.
Okay, keep it there. And now this happens all the time, and we have screen sharing with Indian systems. The previous one, please. The one behind. The next one. All right, don't worry.
What I have is like this only, sir.
Next one.
No,
Next one.
Okay.
I mean this one.
Next one. Yeah, but
Okay, keep it there. Okay. Yeah. This is the International Coalition of Medical Virologists, formed by Dr. Gallo and Dr. Inhart and Dr. William Hall. There's a story behind starting of the IAV. In 2011, these three virologists of international eminence predicted that the next challenge to the whole world will be not a nuclear war, not an earthquake, but viral epidemics, one after the other. And this statement had a touch of prophetic intuition. Here we have 200 million people have been affected with COVID. And he asked, Dr. Gallo asked me and Dr. Sharangatharan on the left-hand side. Sharangatharan can be really considered to be a close associate and a powerful lieutenant of Dr. Gallo in his studies on HTLV1, in the development of ELISA, Western blot, and also in breaking the concept of the Nobel Prize winners, David from MIT, that the retroviruses are only in animals. Both Gallo and Dr. Sharangatharan are credited with the breakthrough discovery that retroviruses can be in human beings also. So both Dr. Gallo and Dr. Sharangatharan asked me whether we could establish a unit of the global virus network in India. We first approached ICMR, Dr. Ganguly. It didn't go too far. And then next slide, please. We went to the Chief Minister of Kerala at that time. This was about 7 years ago. And the Chief Minister was very enthusiastic, but he forwarded the suggestion to two senior officials. Somehow the two top bureaucrats didn't like the idea and it was dropped. I forgot the whole issue. 2 years later, a new government comes and the Chief Minister, Mr. Pinarayi Vijayan, he asked me to come to his office and to my utter surprise, requested whether we can open up the GVN affiliation. I was actually spellbound because I didn't know him personally very well. I didn't know that he had a knowledge of the cancellation of this proposal. So I asked him, I will go back to Baltimore and talk to Bob, and if it is still possible, we will revive this proposal. Next slide. Next slide. We revived and an Institute of Advanced Virology was established at Thomaker. The mission of this institute is mainly to train new generation of virologists, and I emphasize the point, new generation, have international collective research, and develop an advocacy group at the national and international level to further virology research. Next slide. Next slide. The construction, can you go a little slower? Previous one. I don't know why we are having this screen sharing problems with the international connectivity. And with all credits to Sri Pinarayi Vijayan, who surprisingly understands science more than anybody whom I met. The construction work was started in a 25-acre lot at the Life Science Park near Trivandrum, Thomakel. And the construction was completed in record time. Next slide. Next slide. And here it is. It is finished on time. Next slide. Next slide. And it was inaugurated by the Chief Minister in the presence of Dr. Christian Berchot, who incidentally is a Frenchman who heads the Global Virus Network, in a very impressive ceremony attended by a large gathering of Keralites. Next slide. Next slide. And you can see how many people were attending keenly to watch the emergence of the first unit of International Virology Network as a participant of Global Virus Network. Next slide. Next slide. And here you can see Dr. Christian Berchot, and you can see Dr. William Hall, Dr. Sharangatharan, and Dr. Shyam Sundaran Kotal, and a host of the stalwarts of IAV who helped us to establish center on time. Next slide. And everybody was in a very euphoric mood. You can see the Chief Minister. Sitting next to him is Dr. Christian Berchot, the present president of GVN, and myself. And I think if you can expand that slide a little more. Can you expand it? You can see Dr. William Hall and Dr. M.C. Dattan, the chief of the Science and Technology Division, and Dr. John Panikkar, who is the president of our Trivandrum Medical College Alumni Association. Next slide. Next slide. It's okay. So if you look at the milestones of this institute from 2011 to 2021, Dr. Gallo's visit to Kerala to inspire the local administration, it didn't go through very well at that time because it was objected to by two top officials. 2 years later, the Chief Minister takes it upon his own, not on my persuasion. He brings it into a prominent pace of activity with an electrifying effect, and the institution is built. Dr. William Hall, the second genius who predicted that viral epidemics will be the catastrophe of the world, takes over as the external consultant of our institution. Dr. Christian Berchot also visits our institution for its inauguration. And Dr. William Hall and Dr. Christian Berchot joined us for the formal inauguration. And Dr. Shyam Sundaran Kotal joined our scientific committee. Next slide. Next slide, please. Okay. Kerala has a big legacy of accomplishments and excellence in public health. Almost all of you know the story of Maharani Ayilyan Tirunal Gauri Lakshmi Bai, 1791 to 1815, 213 years ago, who introduced smallpox vaccination in Travancore state. This was a time when Edward Jenner was facing strong opposition in England against the cowpox being used to prevent smallpox. The Royal Science Society objected to it. All the surgeons objected to it. Medical establishment was against it. The church was against it. At that time, a small, tiny state in India, Travancore, came forward to start vaccinating the masses. And in order to allay the fear of the masses, the Queen herself came forward and vaccinated in public. Next slide. This is 200 years ago. Next slide. This is Edward Jenner, and considered to be the father of vaccination. The father of vaccines is still the same Louis Pasteur, who is credited with the pasteurization. It's ironic that the country which initiated the process of vaccination has the maximum anti-vaccination group in the world right now. But I haven't addressed this problem with Christian. I would. Next slide. Next slide, please. This is the anti-vaccination past and present. The article is quoted from British Medical Journal. So just for its authenticity, they praise the Highness Rani Gauri Lakshmi Bai for introducing smallpox vaccination 1830, 200 years ago. At that time, Europe was facing strong opposition. Next slide. So GVN today has about 63 centers of excellence around the world. 11 of them are affiliated. Now, after 1 to 2 years, an affiliated center, if it shows excellence, will become a full center. In 35 countries right now. The Institute of Advanced Virology in Kerala is an affiliated center today. We are affiliated to the Institute of Virology in Ireland with Dr. William Hall. We are also affiliated to the Japanese Center of Virology. And it's important to realize that most of our training will be channeled to either Ireland or Japan. And Bill is already standing ready to train our technologists and doctors and virologists. And Japan has come up with a new university where the medium of instruction is English, and they are willing to accommodate 1 or 2 candidates every year for master's or doctoral level training, all expenses paid by Japan. So these are the opportunities knocking on our doors. Next slide. Next slide, please.
Just come.
Okay. Okay. The IAV has several challenges now, not only with COVID, but so many other things. According to the latest information in the newspaper yesterday, we have about 35,000, actually 353,000 cases so far, of which 333,000 recoveries have been reported, 17,654 deaths, and total vaccinated is about 213,000. Actually, 2 crores and 13,000. That's great. We are in the right direction. Next slide. It's not only the COVID that we are concerned about. The Zika, although is a relatively mild disease, we should be concerned about the congenital deformity in pregnant women, because we never know until the child is born. We had a success story in Nipah, but we never know that will come back. We had 19 cases and 17 deaths. Chikungunya continues to be a scourge, although less mortality. Influenza is still a big issue for Kerala. We don't have enough statistics on that. We had major outbreaks in 2014 and 2020. Most of our strains are H1N1. The subtypes still are not elucidated. According to the latest available statistics, we had about 900 cases with 60 deaths. Dengue is actually a complex issue now. We have 20,000 cases and about up to 2.5% mortality reported. What is striking is the association of hypotension with mortality. I lost 2 of my close friends in Trivandrum to dengue in 2020, and both of them presented with severe hypotension and they died. So it is not as indolent or harmless as chikungunya. So we may have to consider that with enough alarm and concern. Next slide, please. Not only that, as an oncologist, I can tell you that we are dealing with the DNA and RNA viruses causing cancer. The Epstein-Barr virus is associated with Hodgkin's disease. It's also associated with some of the lymphomas now. The human papilloma virus is associated with carcinoma cervix and oropharyngeal cancer. The association of hepatitis B and hepatitis C with liver cancer is now well recognized. Human herpes 8 virus and malignant pleural effusions are increasingly reported. RNA virus HTLV type 1. Interestingly, HTLV type 1 was first reported by Bob Gallo and Sharangatharan. And Gallo has always been arguing that wherever there is an endemic area in an island, the neighboring countries will have some touch of it. He predicted that Sri Lanka will have STLV1 endemic zones. They did indeed. And the close proximity Kerala has picked up some of this HTLV. The RCC have more than a dozen, actually 2 dozen HTLV, human T lymphotromic virus or human T lymphoblastic virus-induced cancer detected. More importantly, many of our Ayurvedic hospitals are flooded with muscular dystrophies, myelopathies, and there is a close association between HTLV type 1 and various types of myelopathy and muscular dystrophies. Next slide. The most fascinating area to me today is the concept of a gut virome, which shows that our intestines are flooded with up to 10 to the power of 13 viruses. The total estimate of viruses in the world is about 10 to the power of 23, of which 10 to the power of 13 we are carrying in our system. Are these viruses cohabiting with our system, creating any havoc? There's a lot of enthusiasm in studying this phenomenon. In fact, in adenocarcinoma lung, increasing evidence is accumulating today about the association of virome and oncogenesis. Enteric human viroma is also being associated with colorectal cancer. How do they work? Do they modulate our immune system, or do they have a direct oncogenic potential? We still don't know. Maybe the IAV, Kerala University Health Sciences collaboration will open up in the coming years. Next slide. Next slide. Those of you who have interest in studying this topic further, I would strongly recommend the Nature reviews in March this year, just 3 months back, about the human virome composition and host interactions. What they're pointing out is something which I highlighted right away: the estimated number of viral particles on Earth, and up to 10 to the power of 13 viral particles per human individual, and their heterogeneity are increasingly reported. An association with disease is being explored. Next slide. Okay, what do all these things mean to IAV? Well, University of Health Sciences have a challenging task ahead. One of the problems we faced during the establishment of IAV was the shortage of qualified virologists. India does not have enough virologists to take care of our problems. So Kerala University of Health Sciences will have to start courses in medical virology, studying all aspects of virology, research virologists, virologists with expertise in population health and whole dimension. In fact, I introduced Mohan to one of the best international population health experts last week, and the concept of zoonosis. It is now recognized that 75% of human diseases originate in humans, in animals. 75%, which means that starting from Nipah to COVID, we have a close association with the animal origin of viral epidemics. This is an area wide open for Kerala University of Health Sciences, mainly because of our proximity to 2 major universities, Kerala University of Veterinary Science and Agriculture. So providing human resources in above fields will be the main challenge of Kerala University of Health Sciences in the coming years. More importantly, research on the sequelae of common viral epidemics in Kerala. We have a gold mine of clinical data lying there. Nobody has touched that yet. I think the Kerala University of Health Sciences should take the leadership in studying the sequelae. We already know about the post-COVID syndrome or the long haul COVID. Even dengue, we know, can cause lingering symptoms. Nobody has touched that topic. The whole world is looking at Kerala to give us some information. Partnership with public health experts is absolutely mandatory because we may be looking at the microbial aspect of it, and we need the participation and active involvement of the best brains in public health in Kerala and India. The KCDC is a concept in evolution. With that in mind, a Kerala Center for Disease Control and Prevention. We already initiated some informal discussions with CDC Atlanta, and a project proposal has been submitted to the government. It's under active consideration. When the CDC is in full bloom, what we would like to do is to bring all the brains together, people who are working in medical colleges, various universities in Kerala and outside, under one umbrella, and assign them projects to work on. So there is no cross wall, there is no silos. We will be talking to each other. And that's the whole idea of designing the KCDC. Hopefully, it should come within the next few years. Vaccine production is well known, and even Kerala is considering it. Don't underestimate the technology behind that. You could also look into the technology of vaccine production, and there are resources available for you to collaborate. Next slide. The IAV KUHS partnership potentials is primarily to supply a steady supply of trained personnel. And so I have to work hand in hand with the new director of IAV taking charge this month. Should also interface with virologists, immunologists, and public health experts, all under the same roof. You should also have synergy with adjacent universities of agriculture and veterinary sciences, and explore the expanding field of zoonosis, because 75% of human diseases originate in animals. Exploring the concept of One Health is unique for India. Basically, the concept of One Health defines that our health as human beings is intimately connected to the health of animals, plants, environment, and earth. This was a beautiful concept originated in ancient India. Vasudhaiva Kudumbakam. We are all part and parcel of the same family. So perhaps KUHS is the best place to be the anchor of the concept of One Health, to be the anchor of expanding zoonosis to its full potential. Next slide. Long-term targets will be eradication of communicable diseases. It's a long goal, and it's a dream beyond our reach right now, but not unreachable. Understanding lifestyle diseases, what is the role of microbiome and virome in inducing and sustaining diseases like obesity, diabetes, hypertension, cancer. These are all multi-million-dollar research topics. Can we intervene and prevent these diseases like obesity, diabetes, hypertension, and cancer by modulating the microbiome and the virome? It is possible, and that's the way things are unfolding in research laboratories around the world. Next slide, please. KUHS leadership will have to answer the following questions. Why there are discrepancies in infectivity? We know that in spite of the heavy pandemic going on, Dharavi in Bombay, Maharashtra, a slum area with 100,000 people are dwelling in huts. They didn't have the infectivity we reported from many other parts of India. How do you explain the mortality difference in the first wave and the second wave? First wave attacked more of old people, less of younger people. Even at that time, the mortality among young people, non-resident Keralites in Gulf countries, was unexplainable. How do we develop this immunity? Why do some people, even the best vaccines are giving only 94%? What determines this immunity? Can we modulate that? How long does this immunity last? Is there a role for revaccination, booster doses? All these questions have to be answered by collaborative ventures from KUHS and our academic institutions. What about the post-COVID syndrome? What exactly is causing that? Is there any role for microbiome? If it is proven, you could even invite other systems of medicine, which emphasizes on the health maintenance, and see if other systems of medicine can offer anything to eradicate or eliminate the post-COVID syndrome. Can booster dose issues be settled in Kerala? Even the United States is now looking into that. In fact, the messenger RNA technology has opened up new vistas for vaccine production at a record time. Never before in history of medicine has vaccines been developed in such a short period of time. So that's the emerging field, and the question of booster doses will be addressed very shortly. Can virus mutation and vaccine suitability be addressed? We know that the worst thing that can happen to a virus is multiplication. The more they multiply, the more they are likely to mutate. That's why we don't put too much emphasis on natural infection to develop the herd immunity. If you allow the natural infection to escalate into herd immunity, the multiple multiplications or replications may be setting the ground for more mutated strains. It's an area wide open for study in the Kerala setting. Next slide. Well, IAV leadership should answer. Are early lifestyle diseases partly or wholly modulated by virome? Can early detection and eradication be performed? Can there be a disease-free world? And this is exactly what the King Mahabali was asking. Adhigal, Vyathigal, Onnumilla, Bala Maranangal, Kelkanilla. There is nobody with any disease, distress, or sickness, and infant mortality is 0. That is the dream of an emperor in Kerala, millennium behind history. Next slide. Next slide, please. So, to conclude, I would say that the history teaches us that if you forget the history, you are condemned to repeat it. The initial denial to establish the Institute of Advanced Virology came from 2 top officials, which was corrected by a visionary chief minister. I'm not saying that the officials are bad. I'm just saying that they lack the vision or the farsightedness or the scientific bent of mind to realize this sufficiently early. Had we established the Institute of Advanced Virology, say in 2014 or 2015, 6 years into its existence and development, we would have been ready to answer many of the challenges we are facing now. There would have been less concern, less confusion, less chaos, and less controversy. We missed that bus because of the myopic vision of some official leadership. This was thankfully corrected by an elected leader from the community. So sometimes the elected community representatives have better vision and better scientific bent of mind than whom we consider to be knowledgeable about these topics. So in future, if Kerala University of Health Sciences has a good project which is being denied or rejected by an official dumb, don't take no for an answer. If it is good for the state, it is good for the country, if it is good for the people, bring it to the attention of a visionary leader like the present governor of Kerala or the present chief minister of Kerala. Both have impressed me with their willingness to listen to scientific recommendations and scientific pieces of advice. So in case we can control and eradicate the communicable disease and then embark on a project to eradicate the lifestyle disease by modulating the microbiome and the virome, we are entering an era when we will be going from here to eternity. Remember the Frank Sinatra movie of 1953, which was a record movie attracting worldwide attention. And interestingly, although the Frank Sinatra movie and James Jones novel was written only 60, 70 years ago, the Indian thought process had predicted this in none of these Upanishads. Brihadaranya Upanishad, Tamaso ma Yodagamaya, lead us from darkness to light. Asato ma Satgamaya, lead us from untruth to truth. Mrityo ma Amarangamaya, lead us from mortality to immortality. James Jones borrowed the last line when he coined the title for the movie From Here to Eternity. I wish both these predictions will come true and the partnership between Kerala University of Health Sciences, Institute of Advanced Virology, and other centers of excellence in India will flourish in the years to come. And we can really look back 50 years from now that we have come from Global Virus Network to IAV and beyond. Now we are on a path from here to eternity. Thank you for your attention.
Thank you, MV Pillai sir, for taking us through that excellent platform where we are going to have the 5 days webinar series from here to eternity. And sir has taken us through the global virus network, the birth of Institute of Advanced Virology, the questions to be answered, the opportunities for training, research, and more of improvement in the patient care and diagnosis, including communicable disease as well as non-communicable diseases and the need for One Health approach. Mohanan sir, can we do further, or would you like to add anything after MV Pillai sir's presentation? Thank you so much.
Sir has shown the highway into which we have to enter, and we are ready to enter the highway, and we will definitely reach what Kerala wants. Thank you, sir. Thank you very much. Thank you.
Okay, thank you, sir. Now we are moving to the first day. The topics today we are going to address on COVID-19 variants and their impact. And to speak to us as the first speaker, we have our own Sharada Devi ma'am. Sharada ma'am, as we know, she was HOD of Microbiology, Government Medical College, Trivandrum, and presently she is HOD of Microbiology of SUT Academy of Medical Sciences, Trivandrum. And she also a diploma in medical virology apart from her training in microbiology and from NIV Pune. And she was the nodal officer for the prestigious Kerala Antimicrobial Resistance Strategic Action Plan, and she has worked a lot for putting it into the right way. And I'm very happy to welcome Sharada ma'am to talk to us on COVID-19 diagnostics, how it evolved in Kerala, because she's the right person who has been there continuously from the very beginning in setting this move the right way forward. Over to you, ma'am.
Good evening. Am I audible?
Very well, very well.
Screen is also visible?
Yeah, sure.
Yes,
Okay. So I'll straight away go. Good evening, all dignitaries. I thank the organizers for giving me this opportunity. So we'll see how COVID-19 diagnosis, how it have evolved in Kerala. This I'm not going to the statistics because MV Pillai sir has already shown the statistics. So I'll just skip the slide and I'll go on to the next. So we know 2 Nipah outbreaks gave Kerala health system valuable training and confidence to handle COVID-19. Since Kerala has been alive to the threat of disease from any part of the world due to its expat population and dependence of the economy on international tourism, when the epidemic was reported in China and Southeast Asia, Kerala started preparation for response in the middle of January itself. It started preparation in the middle of January. So when the epidemic was reported in China and Southeast Asia, we took numerous steps to strengthen the guidelines, emergency preparedness, diagnostics, categorization of risk involved in reducing the transmission of the virus. So when the first positive case in India was reported from Kerala on January 30, 2020. And this was tested at the NIV Pune. 2 more cases was reported, that too from confirmed from or tested at National Institute of Virology, Pune. So following the detection of 3 cases in January, Government of Kerala declared a health emergency. But in February, we did not have any case. So health emergency was withdrawn on February 12th, 2020. 8th March, we had 5 cases tested positive. 9th March, 1 more tested positive. So 10th March, 4 labs of Kerala started doing RT-PCR testing. That is the Government Medical College Trivandrum, State Public Health Lab, NIV units Alleppey, and Government Medical College Kozhikode. These labs started RT-PCR testing because we have viral research and diagnostic lab project of ICMR since 5 years, and all we were the labs were doing molecular work. So we had all the machinery and we did not need any training. So we started doing testing. So in the meantime, RT-PCR machines by our health secretary was identified all over the state and redistributed to the government institutions. For example, Government Medical College Trivandrum had only one thermal cycler. So when these RT-PCR machines were identified, they were given to all the medical colleges and also government institutions so that they can start testing. Then human resources. How is the human resources provided? Because we started testing on March 10th. We have done only 3 samples and 1 became positive. But we cannot release the result because we have to send to NIV Pune, confirm it, and then only we were supposed to release the result. Again, March 11th, we did 11 samples. Again, it became 2 were positive. We had to send again. So this continued for about 2 weeks. When there was 100% concordance, we were able to release the results by ourselves. So these labs needed, because we started from 3 to 2,900 samples every day. So we needed more of human resources. That was provided by National Health Mission to all the government institutions. We were provided with research scientists, lab technician, lab assistants, data entry operators, cleaning staff, all were provided. So we were also simultaneously imparting training to other adjacent institutions where they were going to start RT-PCR testing. So we have a very efficient Kerala Medical Service Corporation that provides best health infrastructure services. All the kits, equipments, and all of the consumables were supplied on time to all the government institutions. Then luckily, according to the revised National Medical Commission Regulations 2020, for recognition of MBBS course in any medical college, there should be a DSL level 2 virology service attached to microbiology department. Therefore, all the private medical colleges were forced to start their own DSL 2 virology lab, and as well as private labs across the state also set up these DSL 2 virology labs. ICMR insisted on NABL accreditation also for these private medical colleges as well as private labs, so that the quality of the results can be ensured. Then training was given to all those private medical colleges by government medical colleges adjacent to them. Then, so diagnosis, we know that rapid and early lab diagnosis is critical to diagnose infection as well as to control transmission. There are various techniques by which we'll do that. So I'm not going into detail. So coming to clinical diagnostics, that includes symptoms, laboratory markers, not specific to SARS-CoV-2, and imaging. So there are D-dimer, ferritin, LDH, CPK, all those are available in all these hospitals. So they're not specific to SARS-CoV-2. We have in all medical colleges, we have, and the private labs, we have all these investigations as well as imaging. Then we have the in vitro diagnostics, the nucleic acid amplification test. Gold standard is RT-PCR. Then serology, we have antibody and antigen detection assays. Then antibody assays are not used for diagnosis of acute infection. We'll come to that. So that is for public health or epidemiological investigation, we use the antibody detection. So we have the kiosk for sample collection was established in all parts of the state. Then the RT-PCR testing was started in Government Medical College Trivandrum along with other 4 labs on March 10, 2020. But we were doing manual extraction till July 2020. Then for us, automated nucleic acid extractor was given. And then next month itself, we have gone to Gene Expert. That's a point of care rapid PCR test. So with a 4-module mission, we were doing CBNAT for TB. Immediately that was mobilized for COVID-19. And we started doing, within 1 hour, we can give the result by point of care rapid test. CBNAT started. Then TrueNAT also came to in the May 2020. That also was provided by the Kerala state government. So every government medical college, that is about 12 government medical colleges, have both RT-PCR testing, CBNAT as well as TrueNAT is available. Then came the rapid antigen testing that came in June 2020, and that was done by our PG doctors, that PGs in the hospital. They have done with the rapid antigen, many kits supplied by the KMSCL. but the sensitivity is poor. Then antibody detection by CLIA. We have done a sero survey in January 2021, and that was in January 2021 before vaccination. Now we are going to do the second sero survey by antibody detection using CLIA in this month, August 2021. And for diagnosis of retrospective diagnosis means for diagnosis of multi-system inflammatory syndrome in children as well as in adults and other post-sequel of COVID-19, a positive antibody test can help to support the diagnosis in these conditions. So we use for sero survey as well as for the retrospective diagnosis by CLIA. Next is we have Abbott ID now within a rapid PCR test that is available in the airport for screening of samples since June 2021. Then Acula, that is also a rapid PCR test that is also available for airport screening of samples since June 2021. Now we are going to, discussion has started from yesterday onwards, whether we can go on to for the FELUDA, that is a CRISPR-Cas detection technique, which the results will be obtained within 1 hour. The cost is less than when compared to Gene Expert. Sensitivity is about 96%, specificity 98%. And so we are thinking of this CRISPR-Cas technology developed by CSIR, IGIB as an alternative to antigen. Antigen, the sensitivity is very poor. It's only 50%. And the result we can get, this is a piece, CRISPR-Cas9 testing based on it. So within 1 hour, the result will be available, cheaper and more sensitive, about 96%. Specificity is about 98%. Maybe we will be soon starting FELUDA also. Now, quality control, because we have Kerala, we cannot just go on doing the test from 4 labs. Now we have 173 labs in Kerala, government is 50, private 123. So ICMR has selected 2 QC labs in Kerala to do the inter-lab quality control. One is at NIV unit Alappuzha and the other is at GMC, Government Medical College Trivandrum. It was started in January 2021. All testing labs are asked to send 5 positive and 5 negative to the quality control lab twice a year. ICMR has launched an online portal entry for ILQC activity. So our QC lab, we ourselves, GMC Trivandrum and NIV unit Alappuzha send samples to NIV Pune for quality checking. So from 4 labs, we have come to 173 labs in Kerala. In the government sector, it is 50 and private, it is 123. Next is COVID-19 genomic surveillance that also been started. India, it is INSA-GOG, and we have got our own understanding the genetic for that is GenusCovid-2, understanding the genetic epidemiology of SARS-CoV-2 Kerala, done by CSIR IGIV in collaboration with Department of Health and Family Welfare and National Health Mission. So one of the initial studies were conducted in Government Medical College Kozhikode in July, August 2020. And then we have started the landscaping of genetic epidemiology of SARS-CoV-2 in the state, spanning all 14 districts of Kerala since December 2020. Every month, 100 to 170 samples will be collected from each of the 14 districts and sent to CSIR IGIB on a pre-planned date. Then NGS technology will be done, sequence analysis updates will be done, and it will be communicated to Government of Kerala on a weekly basis. Summaries of the analysis and key observations are available in the web portal. This is, as MV Pillai sir has told, this is our future. We are all looking for this to develop institute for our state, that Institute of Advanced Virology that was established in Thonekal. We are looking up to it for all our future virology work. Hope this will start functioning very soon. That is the wish of all Keralites to see this working, start functioning with all the advanced techniques, Okay, thank you so much.
Thank you, madam. Thank you for giving us the introductory way how we are moving from the test, and now we have reached up to possibly FELUDA and the Advanced Virology Center, and we have a lot of things to come in future. So next we will be moving on to a, before going to the topic by Dr. Gabriel, we'll have a brief introduction by Dr. Sri Kumar, He's scientist from RGCB Trivandrum. So we'll be talking on RNA sequencing in COVID-19. And sir is the head of molecular virology laboratory, Rajiv Gandhi Center for Biotechnology. He has a master's degree in immunology and PhD in biotechnology. And presently he is in Rajiv Gandhi Center of Biotechnology from 2004. And so has been instrumental in most of the researchers like especially in chikungunya and dengue virus research programs. And he has been instrumental in during the explosive outbreaks of these diseases with molecular diagnostic services. Over to you, Sri Kumar, sir.
Thank
Thank
you. Can I get the screen sharing, please?
Sir, you are allowed to share your screen, sir.
So I hope this is visible.
Yes, sir.
Yes.
Okay. So let me first of all thank the organizers for giving this opportunity. So I thought I will start with the very basic science little bit, so that I understand that there is a heterogeneous group of people in the audience and the listeners. So maybe I can give some basics so that when we move to the advanced sequencing analysis, it will be useful. So the first point is why genome sequencing in viruses. So of late, we see that a large number of, almost all of us have turned into virologists, and everyone is speaking about variants and sequences and RNA viruses, DNA viruses. But many times, most of us don't understand what is the basis behind this. And I thought I can try to shed some light into this. So genome sequencing has become a part and parcel of virology research. So essentially, in the beginning, we just had to do an ELISA or just a PCR to say that there is a virus around. But now, to confirm the identity of a circulating virus, genome sequencing is considered as a gold standard. So I remember some 15 years back when I ventured into this virology, it was in the wake of outbreak of chikungunya in Kerala. So we were just started doing PCR diagnosis. Maybe RGCB was the first institute in the state to start a PCR. So we were getting a lot of requests for doing the PCR, and I was interested to start this. Then I got a PCR amplification, but I insisted to our directors that we cannot report this unless we do a sequencing. So just by getting a PCR, especially conventional method of PCR, we will not be able to identify or confirm the identity of a virus unless we do a sequencing. So at that time, sequencing was a rare thing. Now we have moved from first generation sequencing to second generation sequencing to new generation, different modalities of sequencing. So now it has become a gold standard. So genome sequencing in viruses has become extremely important. Then second is to know about the variants of different viruses or circulating viruses to correlate with the transmissibility. Especially this is very important for deciding on the public health interventions. And we will hear a lot about the emergence of the Delta variant and how this has become extremely important to know the circulation of this particular virus variant. Then correlation with the disease severity. So that is also extremely important, understanding a genetic correlation, some mutations that is affecting the key proteins, key genes or proteins, which will decide on the severity. So that is extremely important to understand the disease pathogenesis. Then vaccine escape or need for new vaccines. Every year we have new influenza vaccines coming up, and essentially the understanding about the sequences are extremely important to generate new vaccines. Then antiviral treatment or resistance development, we have been dealing with chronic diseases like hepatitis B and hepatitis C. And every time, whenever there is a drug resistant mutant arises, this is understood by essentially by sequencing. Then there is always a curiosity among all the scientists to know how these viruses have evolved, because these are one of the oldest pathogens that is surviving on Earth. And we would like to know how these have evolved, how they originated, how they are spreading. And even there are a lot of questions about the origin of the SARS-CoV-2 virus, whether it is from bat or whether it is engineered or whether it is from some other sources. So all these answers have to come from the sequencing. So genome sequencing has become part and parcel of our virology research. Moving on, maybe this is just a refresher to all our old textbook knowledge. So most of us know there are RNA viruses and DNA viruses. Just look at the structure. So RNA is made up of ribose nucleic acid. The sugar is ribose, and the DNA is made up of deoxyribose nucleic acid. So apart from that, the bases that is present in the RNA is uracil instead of thymine in the DNA. And RNA generally it is a single strand, and DNA it is double strand. But there are exceptions in biology always. Then there can be double-stranded RNA in viruses and single-stranded DNA in viruses. And this is very important. This is one of the immune recognition mechanism by the body. Especially this double-stranded RNA and single-stranded DNA is recognized by the innate immune system to induce an interferon response. That is the first line of defense by the body. So these exceptions are recognized by the body to protect us. And as almost all of us know, the SARS-CoV-2 virus has a single-stranded RNA, which is a plus sense RNA. So those of you don't understand what is a plus and minus sense, this plus sense means once this RNA enters into the body, under the cytoplasm of the cell, it can directly get translated into a protein. So if it was a minus strand, then it has to be converted to a plus strand, and then it has to get into a protein. So there will be some delay in making the protein. But this virus, once it enters in the cell, straight away it can start replicating by making the proteins. Now, understanding the genome of this SARS-CoV-2, we can have two approaches. It can be a targeted sequencing, looking at essentially the specific genes which are important for our interest, or the whole genome sequencing. So the conventional or the old method of sequencing was the Sanger's method. You can say it is a first generation sequencing. And now we have the new generation sequencing, or a next generation sequencing. So that is also keeping on evolving, like from the first generation of the Sanger sequencing, which we could get around 500 to 1000 base pair fragments. In the second generation, third generation, by the third generation, we can get longer reads. And with the support of a computational biology, we can even make the complete genomes. And the flowchart of a next generation sequencing, this is adapted from some web images, but generally it involves the extraction of the nucleic acid, especially if it is an RNA, it is made into a DNA by RT-PCR, reverse transcription, then fragmentation of the DNA, adaptive ligation, and library construction. And all this will finally end up with a significant amount of bioinformatic analysis to make the whole genomic segment. And interestingly, the Sanger sequencing, by that way, it is a simpler method. And for targeted sequencing, it is one of the easiest and less costly affair. But when we take this to a longer read length sequencing, larger genomes, it becomes more costly. So when we have to do for whole genome sequencing for larger viruses, or larger genomes like human genome or any other genomic project, we always go for the whole genome sequencing. Now, in case of SARS-CoV-2, as all of us know, the length of the genome is around 30,000 base pairs, and it codes for the non-structural proteins and the structural proteins. And the genomic sequencing, we could identify that this is closely related to a bat coronavirus, and this is based on the whole genome sequencing. And in the, most of the time, especially to study the virus transmissibility, or also to understand about the vaccine escape mutants, and also looking at the variants, we focus on the structural protein, especially the spike protein, which is projected on the surface of the virus. And this is one of the major protein that is getting exposed to the immune cells. And also it's always formed as a trimer, which is getting projected on the surface of the virus envelope. And in this spike protein itself, this is a receptor binding domain, which is much more important in its functionality. And we would see that this receptor binding domain will interact with the ACE2 receptor to facilitate the virus entry. So any changes that is happening in the receptor binding domain will be important in deciding the transmissibility of the virus, infectivity of the virus, and also in deciding on the response to neutralizing antibodies. So that is why I mean, if you look at the genomic sequences that has been published so far, most of the major variations which are functionally important, like the increasing the infectivity or decreasing the infectivity or sensitivity to neutralizing antibodies, they have been mapped to the receptor binding domain of the virus. And this is one of the major or hot targets for looking at the variations in the SARS coronavirus. And we know that the virus has been keeping on evolving, and it has moved from alpha to beta to gamma to delta, which is becoming one of the major variant that is taking over the world. And so far, we don't see further evolution of this virus with respect to its major functionalities, even though in between we could see some delta plus variants emerging, but they seems to be not further progressing. But maybe the next speakers will be able to give more information on that. But essentially, most of the mutations which are functionally important are still identified in the receptor binding domain. That does not mean that the other regions of the genome is not important. They would be important in the infectivity, especially in the virulence of the virus, and also in the pathogenesis. So we are still to know what are those mutations which will be important in the pathogenesis. So in the genome sequencing of SARS-CoV-2, our institute entered very recently, and most of our focus has been on targeted sequencing. As I said earlier, we have been focusing on the receptor binding domains in a region which is a functionally important domain. And what we do is we get the sample, isolate the RNA, and go for a targeted sequencing using the conventional Sanger sequencing method. So this is not a high throughput kind of, you can sample, but also like it will only do a small segmented regions. And but that is becoming essential or maybe sufficient for understanding the emerging variants. It may not be able to pick up larger genomic regions, but the receptor binding domain can be covered without much difficulty. So we have been sequencing a number of samples so far. And we could see that more than 98%, or maybe of late recently, almost all the 100 samples, 100% of the samples are becoming the Delta variant in our state. And these viruses we get from high TPR areas, from clusters of infections, reinfections, and breakthrough infections. This is the Delta variant that is circulated. The larger genome sequencing is being done by the consortium in India. So they also have very interesting observations, I think, which will be shared soon in the later course of the presentation. So when we do the phylogenetic analysis, we can see that most of these sequences, this is a representative samples from a cluster. We can see that they are clustering together in the phylogenetic tree. So this is a very brief overview of what we have been doing and the importance of the sequencing. So our targeted sequence analysis reveals near 100% of circulation of the Delta variant of the SARS-CoV-2 in Kerala, especially in the 4 districts that we have analyzed. So we could see this Delta variant in clusters of infection, samples from high TPR areas, samples from reinfection and breakthrough infections. And we could not see any correlation of this Delta variant with severe diseases so far. So further studies are required. So this, to conclude, the sequencing of this RNA genome of the virus, especially the SARS-CoV-2, has become an important tool in the in our decision making. So I would like to conclude with that. Thank you for this opportunity.
Thank you, Sri Kumar sir. So we are now moving on to the next presentation, that is COVID-19 variants and their impact. And I'm very happy to introduce Dr. Gabriel Gonzalez. And he himself mentioned him as a clinical bioinformatician. And it's really fortunate that you be with us in today's presentation. And he's from National Virus Reference Laboratory, University College Dublin, Ireland. And he is originally from Costa Rica, graduated in computer engineering from the Costa Rican Institute of Technology. It is master in bioinformatics and PhD in bioinformatics and bioengineering in the Hokkaido University in the Northern Island of Japan. and in the postdoctoral position in the Research Center for Zoonosis Control of the Hokkaido University. And he's presently holding the position of Clinical Bioinformatician, National Virus Reference Laboratory, University College Dublin, and his main focus of publication turns around virus evolution and methods to assess the molecular mechanisms of such a process. And I think he prefers to take up the questions immediately after the presentation. So you can put the questions in the chat box itself, and immediately after the presentation, we'll have a discussion. But at the end of the session, we can have questions from all the other speakers. Thank you for joining us. Over to you, Dr. Gabriel Gonzalez.
Thank you so much for the introduction. Can you hear me well? Hope so.
Yeah, you are audible. And
Okay,
slides
great.
are also visible.
Okay, that's great. Thank you so much. Well, first of all, I would like to thank you for the opportunity for giving this presentation. Also, well, this is on behalf of Professor Hall. He was invited to give this presentation, but he was unavailable this week. So he kind of put me in charge. He told me like, oh, please present this. He helped me to make this presentation. I hope you enjoy it. Actually, before starting, I would like also to thank the previous speakers because the presentations were great and that helped that my presentation can move smoothly. You will see many of the topics are very related. And well, thank you. Let's start. My talk today is about molecular characterization and identification of SARS coronavirus 2 variants in Ireland. A little overview of what I'm going to cover today. I'm going to talk first to introduce what are the Ireland by the numbers. I want just to create an image of how are the numbers because of course the proportions and the population is a lot smaller of what you are seeing, but having that in the context, it will be easy to understand what we are doing here. Then I will introduce what has been our approach for sequencing and how this sequencing have played a role nationally for the development of measures to control the spread of different variants and to try to curb the number of cases and how that was successful in many cases and some cases were not so successful, but we will cover that. And also how the sequencing has played a role to develop or put other techniques that can help to quick diagnosis and quick reaction to the information. And all this, I will wrap it up with what are the lessons that we are learning to the future? Because yeah, right now the focus is getting out of this pandemic, but what we are surviving, what we are taking now is the learning that we will replicate later and that we can prepare for future pandemics. And well, not even pandemics, in some cases it could be outbreaks. What we can learn right now can be used to prepare for the future and we can get stronger. Well, first, let me introduce a little bit about Ireland. Ireland is, well, in comparison, it's a small country. The population is 5 million. The size is 70,000 square kilometers. I'm describing here only the Republic of Ireland. It's important that you remember that Ireland is divided in two. The northern part of Ireland belongs to the UK, but that creates also an interesting condition because it shares a land border and UK had different measures and different policies. And then that created in some points during these 500 days of pandemic, that create some points of entry for the different variants of, for the different lineages. The first case was reported in Ireland in February 2020. So 1 month after India, we were starting to have the first cases. In the 500 days since then, there have been 279,000 diagnosed cases with 5,000 deaths. Again, in proportion, it's a lot. Maybe it doesn't look like that by the numbers, but it's important to keep the context in mind. The cases have been distributed mainly in 3 different major waves. Well, there's an asterisk there because when I was doing this, we were very optimistic and we have only 3 waves. Right now we are in the 4th wave, but we will see more about that later. The initial wave was at the beginning of last year in 2020 after February. This was the wave that is pretty much all the countries suffered something similar. That is the surprise of receiving the virus. Even before it was called a pandemic, maybe all the different countries were optimistic that it will be different with us. And well, we suffered all an initial wave. The number of casualties was higher compared with other waves because we just not prepared and we didn't know enough about the virus. Or at least that's how I interpret these numbers. I have two diagrams here. You see the number of cases daily and the number of deaths daily. The second wave was after the summer. After the first wave was recovered, many of the countries opted to open the borders, remove all the measures, and then a new set of variants distributed in the different countries, and that increased again the number of cases. Interestingly, those cases, as you can see, increased the number of cases, but the number of deaths remained kind of constant. That was good. However, at the beginning of this year, we faced the coming of the Alpha variant. This is was known for a while as the English variant. And if you know a little bit about the names that they have is B117, let's call it just Alpha variant. And that was after December, January, that we saw a rise in the number, really steep increase in the number of cases daily, and also in the number of deaths. Again, the series is because right now we are living a kind of fourth wave, that is the Delta variant that was mentioned earlier. Thank you. This one, we will see it has some particular characteristics because now the scenario has changed. And I think that that's something to consider in each of these waves. The scenario is constantly changing. It's not only the virus, but we are also learning more about the virus, how to detect it. As you will see, we are more prepared, but also the different conditions keep changing. What is different in this fourth wave? Well, more population is vaccinated. And that changes what are their reactions. Even if a person gets sick, if they're vaccinated, they have more chances of not developing symptoms or developing milder symptoms. But well, conditions keep changing. We can have a discussion about that later. Well, this is just by the numbers, quick diagrams. This is the number of cases that we just saw. This is the number of daily deaths. This is the number of hospitalized patients. And this is another interesting figure, the number of ICU patients. That's important when we are following, not only following the number of cases, but also what is the real impact at the level of public health. What is the number of patients that are going to hospitals because of symptoms? What is the number of patients that they really need attention? In this case, as you can see, the third wave, the Alpha variant wave, was a big change and it required a lot of work to get it under control. And once again, we are right now here starting the Delta, but we haven't seen an increase yet of hospitalized or ICU patients. Also, you can see here how over this time, we have been working to increase the number of tests. So to be able to detect properly, diagnose quickly, and take containing measures on time. Now, that's pretty much some statistics, just the numbers. What have been doing during this time to get more information, more data that can help to the design of public health measures. As it was described before, I will just quickly overview what is the process that we are following. We are taking an approach to make the whole genome sequencing. There are a couple of advantages that we are taking here. In this case, we are following the flow that we are taking is doing the whole genome sequencing using MinION technology. This is next generation. What it does is gets the whole genome sequence. Okay, what advantages that we have with that? Well, we have been working with the protocol and it takes really reduced time. In 1 or 2 days, we can get the whole genome and we can prepare multiple plates simultaneously. As you will see later, I have a little diagram there, but we can prepare with a reduced number of people, 5 people, less, a couple of times. It has been only me and one of my colleagues preparing all these 500 samples in a single shot. And per week, we are sequencing around 1,500 samples and producing 1,500 genomes to report. and that cover a lot of the different regions of Ireland, so we can know what are the different lineages circulating. Well, how it works, the process is simple. Well, simple here, it takes multiple steps, of course, but first, the specimens are collected. These specimens are those samples that are detected to be positive and with a specific amount of viral load in the test for RT-PCR. We can detect what are the positive and we move them for sequencing. Then the viral RNA is extracted. A library is prepared, transforming that RNA into cDNA. And that cDNA is prepared with the different consumables required to use MinION technology. Another optional is working with Illumina. Many different labs are more used to working with Illumina. MinION during this pandemic just grew a lot. Now they offer a lot of different protocols that allow sequencing of these genomes. And then using the MinION, a small device is smaller than actually an iPhone. Smaller than that, it's just plugged to the computer and allows to read whole genomes with deep sequencing and allowing to get really good, high quality genomes, sequences for these genomes, and then proceeding to the data analysis. All these sequences are prepared, and are submitted to GSET or to different databases that allow to put those sequences available for the rest of the world and allow comparison between the different countries. We will see a couple of those examples very soon, how having this data and making this data available help to understand how the different lineages are circulating or moving. Well, just again, this is the figure of the daily cases. And this is how we have been growing in the number of sequences reported per week. As you can see, at the beginning of this year, it was clear that it was necessary to grow the number of sequences that we were getting for the whole country. One of the reasons was because alpha was identified, and then we needed to know what are the different variations between these viruses. At the beginning of last year, all the viruses were very similar. We can think that all of them were kind of clones, but as was expressed before, was presented before, when you have a virus that starts jumping in the population and gets more replications, start accumulating mutations. And then we want to know what are those mutations. And then we want to know if one mutation is starting to grow in frequency over others. If you have one mutation that starts to grow in frequency, it's very likely that that mutation is advantageous for the virus. And then you want to know why that particular mutation is helping the virus to replicate more and to infect more people. And then that's why at the beginning of this year, we start taking different policies to increase the number of sequences that we could produce with the number of samples that we were taking. I will tell you soon what are those policies, because maybe those could be some ideas for the different projects that you have over there. But well, you can see here the distribution and how we start at the beginning of the year, growing the percentage of samples that we are taking and making the sequences. As the National Virus Reference Laboratory, I work, one of the objectives is just identifying, diagnosing, making the diagnosis of the presence or not of the virus. But having now those samples, having the diagnosis as positive, some of them are moved to get the whole genome sequence and identify what is there or not. These are the policies that we took over this year. Last year, we started experimenting with the protocols to get the whole genome sequencing. Then, as you can see, we were reporting per week less than 100. In a good week, maybe we have 140 sequences over the last year. That was following the original protocol for MinION, ONT MinION. This is the Arctic protocol. Then at the beginning of this year, we start using the low-cost protocol. That reduced the time to prepare the samples from 4 days to 2 days. I included here the link. I will make available this presentation so you can click later and go and see the different steps. All the different steps are there one by one, so you can follow it if you're interested in following. And that was for the low-cost protocol. As there was an immediate need for more sequences, We also contacted other laboratories for doing some outsourcing and increase our capabilities of sequencing, even if we didn't have yet the facilities here to do that. So it was a temporal measure, but we ramp up our own capabilities. We also changed from that little device that I mentioned before, that it was the size of an iPhone. We moved to use GridION. GridION is in the same family of Oxford Nanopore technologies. The only thing, well, not the only thing, the thing about this one is it increases from one of those devices to an equipment that is 5 times what it was the original little ONT MinION. This 5 times, it means that rather than working with 96 samples simultaneously, now you're working with 480. And you can get the results in 1.5 days, even less than that, if you're not too picky with the quality. In this case, we decided that we want to really always produce almost complete genomes, high quality, so we are running it 1.5 days. And then we also recently moved from the low-cost protocol to the midnight protocol. This reduces from 2 days to 1 day. Actually, it's 6 hours, what it takes to prepare the samples for doing the sequencing. These little changes have moved that right now we are sequencing 1,500 per week. This is actually now, this is the big picture, how we use this data to inform the decisions and the measures that can be taken all over the country. One of the things that you are, well, what you are seeing here is the distribution of the different lineages, and more recently, call it just different variants that you will hear a lot in the news. At the beginning of the pandemic, 1 year ago, in July of last year, there was this B1-258. That was the one that was circulating. Little by little, you can see how the one that became the summer wave, the summer epidemic wave, was taking over and how was replacing the other. And this was just for the measures. There is not actually, there is no evidence that there was some particular advantage on the virus, but it was just taking over because the measure was relaxed and there was a kind of funding effect. Then it came up the Alpha variant here at the beginning of the year, well, between December and January of this year, and how that replaced completely, not smoothly, steeply replaced the other variants circulating. And well, right now, you're probably, you have heard about this little fella here, the Delta variant. That's the wave that we are fighting right now. Just one example, well, this data is of course from GSET. If you haven't used it, I recommend you to use it. It allows you to analyze data from the different countries. You can visit the website and you can get an user really easily. And this is a graphical representation of how in Ireland, it changed from here in October. Then November, you can see a little bit here of red introducing. In December, there is more coming. This red represents the Alpha variant. And in January, you can see how it replaces completely what it was before. And in February, you have dominance completely. February is around. Yep, you have dominance of this Alpha variant. Something else that you can see here is how, in comparison with October and November, you have a lot of transmission from outside. Many of the viruses are coming from other countries to Ireland. And December, in January, as you can see, you can notice that there are more branches going inside the country. That is the communitary transmission. That means that the virus are moving so strongly inside the country that it's easy to track, that are not coming from other countries. That actually you have variations that are coming inside the country and that are being created inside the country, and just track that movement without going outside. Well, so I mentioned many times already how this genome data informs the interventions and how they can help design measures. I want to discuss a little bit more about that. So interventions to limit transmission, that's the idea of having this information, is transforming well, this data into information that can help to curb the number of cases, and can help to stop the spread of these lineages. One of the measures taken here is limit the movement of population between counties. That's of course controversial because many people is not happy to be told where they can move or not, where they can travel or not. However, epidemiologically, it's successful. This diagram here that you're seeing, it shows these 4 different variants and how they have been distributed in different regions, healthcare regions of the Republic of Ireland. As you can see, there is clear distribution of some lineages and how they kind of remain contained on different, on specific areas. This is over the same period of time and how they can be considered to be contained to those specific regions. Of course, there are some leaks. Still, there is some trouble for some particular people, jump between areas, but you can see specific patterns between the East and the West. Also, this data can be used to track the origin of variants. What I mean by this is you can, with this data, you can test different hypotheses. One of them is the introduction hypothesis, that the transmission is due to travel or contact with travelers. That's as we saw earlier on October and November, that you could track that the virus were coming from other countries because they were highly similar to genomes circulating in other countries. However, there is the alternative hypothesis, that is the community hypothesis. That is that the cases that you're seeing, the virus that you're seeing in different patients is acquired by contact with other people in the same community. That will flag that there is loss of control in the transmission of the virus. One example is this one in favor of the introduction hypothesis, of the community hypothesis, where all the viruses for a specific region, in this case is this variant, the B11318, was, even if we sample in different moments in time for that specific region, we got all of them, the green is for Ireland, all of them clustered together. There is one here and one here, but in general, most of them were clustered together. That means that this was a community transmission, that the virus got introduced to the country and started spreading in the same area. One of the good things about this one, it was contained only to that region. Another alternative, another alternative analysis that can be done is outbreaks can be tested to test if there is single introduction to a specific region or to the country, or if there are multiple introductions. That means that there is a flow from a different area or a different country to a specific region. One example is this one that I'm showing you here, is all the different countries in Europe for the, well, this one is, I think it's Kappa, the Kappa variant, B1617.1. And maybe, well, I know the phylogenetic tree is hard to read here, so I highlighted here the different points involving strains from Ireland. As you can see, there are multiple entries to the country. So in this way, we can see that there is a flow from all over the place coming to Ireland, and that's the cases that we are detecting. Another one, and more exciting, is using these genome sequences to develop new diagnostics, to develop new techniques that allow you to identify the lineages quickly. Why is that? Well, whole genome sequences have many advantages. You have the complete information for identification of mutations. As mentioned before, is the golden standard, because you have the whole genome, so you have all the data, that you want to know about that genome. There is no space for unknowns about the genome at least. And you have confidence on the lineage identification because you know all that is there about that virus in the genome. However, it comes with its own disadvantages. As faster as it is, as much as we work to improve, optimize the pipeline, and as exciting is right now for this pandemic, having this tracking on real time, it takes between 1 and 2 weeks to put all the samples together, because They have to be extracted, they have to be put together, they have to be checked for quality. So it will take always time to get them there ready for sequencing. Preparation of the samples requires certain minimum amount. It is not, whole genome sequences is not for all samples. You need a minimal amount. If you have less than that, if the quality of the sample is not good enough, if the genomes are too partitioned, the process will fail. And most of the sequences, even when you get the whole genome sequences, most of them are virtual clones. What I mean by that is most of the genomes are very similar among them. Well, one example, we made a report of a case on a family of 6 members, where the child was suspected to be the origin and transmitted to the parents and uncles. But when we did the analysis, it was not like that. But all that decision was based on a single mutation, because at the end, all the 6 genomes were almost identical. So even all this work can mean that all the genomes that you're getting are very similar, which is good and which is useful in the cases that I mentioned before. But when you are trying to sample thousands, or well, in India it can be millions or tens of thousands at least of cases, and trying to make the diagnosis of those ones, then it's a lot of work and the return could be little. Then what can we do with that? Well, one of the things that we did here at least was we analyzed the different variants that were available. As you know, the alpha that I mentioned, that was the third wave, the beta that was mentioned as the South African. We tried about now the geographic identification, the gamma, and more recently the delta. And it was mentioned in the previous presentation, there are specific mutations that affect the RBD. That's the region binding the receptor in the human cells. So mutations there are very interesting because that could determine if they are more transmissible or if they can escape the antibodies. So identifying these mutations allow to make the difference between the different variants. And one example here is the common to alpha, beta, and gamma is the presence of this 501. Is the amino acid 501 in the spike protein sequence, that it changes from an N to a Y. As you can see here, that change in the amino acid is tracked to a single nucleotide mutation from an A to a T. Similarly, in the delta, there is one famous, that this one in the position 452, that it could be the one that is conferring some potential escape abilities from the antibodies for vaccines. Research is still being done on that. And that mutation is because nucleotide mutation in this particular position. However, when we analyze this, it's difficult to pick up these mutations, so we can focus also on a mutation that is they come together, that is in the amino acid 681. So using this kind of particular specific mutations, we developed a primer and probe to use in an RT-PCR. So independently of how good is the sample or not, we can take those samples and put it on the positive samples and put it on a RT-PCR to detect if the mutation is present or not. When the mutation is present, it will show the color. It will show in the diagram in a specific color, or it will show in the other if the mutation is not present. That was for alpha and for beta. This was with this particular mutation. As I am showing you here, this one is for the delta variant. It's possible to do the same, focusing on the mutation 681. If this mutation is not present, this is the wild type, then it will show this particular canal in the RT-PCR. And if it is present, it will come in this other canal. Just to show in the same sense, other mutations can be identified to distinguish. This is for the delta variant. Delta variant delta variant has 3 flavors because it keeps evolving. The virus will keep evolving and developing new lineages. And now we have, well, as mentioned before, there is the delta plus, that is this these two on top, and there is one more common. This is the one that we are seeing more in Ireland. That is the AY3. And using this website here, I recommend you can go and play with that. I recommend it because you can compare different lineages and see what are the mutations that distinguish those ones. For example, in this case, you can see how this particular mutation is good to distinguish if it is the AY2 or if it is 1 or 2, and what is the frequency of the different lineages that have been sequences. Well, another next step is sequencing strategically. At the peaks of the pandemic, when you have most of the cases, you need in those cases, you need the most of information around the whole country. What is going on? What are the lineages? What are the different variants that are going around? But in that moment is when it's more difficult to get that information because the amount of samples, of positive samples, is just overwhelming. So it's better to work strategically, and rather than trying to sequence everything that you're getting, trying to sequence more intelligently, more strategically. That means sampling according to your proportions. In this case, these are the different health regions in the Republic of Ireland. So we get what are the number of samples, what are the number of positive cases for each of those regions, and what is the demographic of those ones by age groups. And then among the positive samples, we target to get the sequences of a proportion. In this case, 1,500 samples from the 14,000 that were available during that week. Just that distributed by geography and demographic. And then that sample can inform us how it's moving into the different lineages. So just to wrap it up, sorry, maybe I extended a little bit, my apologies for that. I just want to mention what are the different lessons that we are taking from all this that could be applied for future outbreaks or future pandemics, maybe. One of them is the real-time epidemiological tracking by whole genome sequences. This is the first time that we can have this information in real time, getting complete genome sequences, and that we can take action with that data rather than analyzing posts. There are new bioinformatics tools that allow to provide automated analysis and provide answers more quickly. There is also new vaccine technology that is easier to adapt and to mass produce with the mRNA vaccines. So we could start thinking what is the future for vaccines and what other pathogens could be safely explored, especially when you have endemic diseases or endemic pathogens. What could be attacked next once this is over, and that we can develop vaccines to eradicate those diseases. There is also new techniques developed for inexpensive serological tests. So we could also think, what else can we do with this for the early detection of pathogens or their movements across the globe? One important part that has been played in this during this pandemic is now we can share data, and share data that is publicly available. Then, of course, there is some concerns about the data protection, and that's important. But once that is solved, for example, the sharing only the age range, not the specific age of the patient, or sharing the sample of the date of the sampling, or the geographical location, maybe not so specific, but just good enough to inform different data policies. Then sharing all this data allows to create context. In my case, the data shared from other countries allow me to identify when different lineages are coming here and from where, more likely, we're coming. This data is available as soon as possible. For instance, this morning, I submitted around 500 new sequences over the weekend to GSET. I just received an email telling me that that data is available for the rest of the community, and that community is global. The data, the analysis, the results are constantly automated and updated. And the data is promptly shared for everybody. Not only for Irish community, not only for the Irish group, but for all the world. And then decisions can be taken, content can be made, collaborations can be established. And that's, well, that's exciting. For bioinformatician, that's very exciting because it's sharing data and analyzing new things. Well, I want just less than 1 minute, give, of course, credit where credit is due to Dr. Kilian F. de Cascon. He's the laboratory director. Michael J. Carr, he is my colleague doing actually the sequencing. I just do the analysis. And Jonathan Dean, he's the one putting together all the samples. And of course, Professor William Hall, that he is the one that allows these collaborations to happen. And the rest of the names here are the people that are actually preparing the samples and the day-to-day. Something is remarkable. This little group here is the one that is producing all those sequences. And that is because the technology allows small groups to analyze really big amounts of data. Just one more thing is, if you have any questions, you can write me at any time to this email here. And as it was mentioned in the introduction, I studied in Japan. So if you have any questions about maybe scholarships or studying in Japan, I could help you also with that. I spent 11 years in Japan, and it was one of the best decisions of my life. I learned so much, and I'm so happy. So if you want to talk about that one, that's also possible. Please contact me. And if you're interested in this presentation and you enjoy it, please take a screenshot of this link here. You can download the presentation. And if you have any questions, please. Thank you so much.
Thank you. It was a very, very interesting presentation, exciting presentation, I should say. And you have just told us how best we can use the information from whole genome sequencing and whatnot. You have taken us how to use this information in an epidemiologically successful way, how to use this information to limit transmission, how we can use it for hypothesis generation and all whatnot. It was so exciting a presentation. And if there are any questions, and you have also given an opportunity to go further with regard to scholarships and other things from Japan. That's all the more thank you. And thank you for that information. And many youngsters are actually interested in to take up these areas in Kerala too. And it was also interesting how this can be utilized, this mutations of interest, how we can use in new vaccine technology, and how to interpret for taking up for serology getters. So there are a lot more scopes than what you said, and how the knowledge is uploaded. The way that you said you uploaded around 500 reports in the morning. So it's really available also, that information. That is another good thing about genome sequencing that is happening with this COVID-19 pandemic. It has taught us a lot. And thank you for this bright presentation. And if there are any questions, quickly to this presentation we'll take up. But otherwise, we'll have a discussion after Dr. Vinod's presentation. MV Pillai sir, do you have to add anything to the comments, or we'll move to Dr. Vinod's presentation and we'll have a discussion after that?
I think all of them were excellent, quite relevant, appropriate, and all the speakers were outstanding.
So we have one more presentation, sir. We have one more presentation from Dr. Vinod Skari.
Yeah, let's go ahead. Let's go ahead with the
Yes,
presentation.
okay. Thank you. Dr. Gabriel, I'll just see whether there are any quick questions in the chat box. Or we will take up the questions after the next presentation. Is that okay?
Yeah, let's do it that way. I will reply a couple of them here. It's okay.
Okay, it will be, okay. And now I am very happy to introduce Vinod, because Vinod did his MBBS from our own institution, Government Medical College, Calicut. And he is the principal scientist, CSIR Institute of Genomics and Integrative Biology. And he is the adjunct professor in Tripura Institute of Information Technology. And another important thing is he's the co-founder of the Genomics for Understanding Rare Disease India Alliance Network. It is known as Guardian, and which is one of the largest networks of clinicians and researchers in India working on rare genetic diseases. And as we have listened to Dr. Gabriel, how he offered for the training of the youngsters or scholarships opportunities. Vinod has also established one of the earliest fellowship and education programs in genomics for clinicians in India. And he has been closely associated with genetic epidemiology, and he is involved in the state level genomic surveillance programs in India with regard to COVID-19 and earliest reports with regard to immune escape variants in COVID-19 reinfections and vaccine breakthrough infections. And as we have already said, he was also a proponent of open data approaches and has been well quoted in most of the press. We usually listen about Vinod's presentation, and he has 180 research publications. And I'm very happy because he's very close to me. That's why. So over to you, Dr. Vinod.
Thank you, Madam, and thanks for the nice introduction. Over the next 15 minutes or so, let me give a brief overview of what we do in India in terms of genetic epidemiology of SARS-CoV-2. Before I start my talk, let me also say that this was possible because there was a paradigm shift, and this paradigm shift happened almost in the last 1 decade. And that is possible because of the scale and throughput of sequencing that was available thanks to the technologies in the last 1 decade. And what has really changed is the methodology to not just detect viruses or detect pathogens for that matter, but also to add on to the detection in terms of molecular epidemiology. The former speakers have sort of alluded to that, so I'll not delve deep into this. The basic principle of using genetic epidemiology is the fact that practically all organisms have a very constant rate of mutations. And for SARS-CoV-2, this mutation rate is pretty much constant, approximately around 3 to 4 mutations a month. Now, if you space mutations which occur random on the virus background and which sort of occurs in sort of a Markov chain in the fact that new mutations occur in the background of existing ones. And if you look at the time scales of genome sequencing at each points in time, what you expect is practically all the lineages to be equal proportions, but that's not really what happens in real life situations. What you really see in real life situations is one or the other lineage which predominates other lineages at each of these points in time. Now, this is what we call as emergence events, and emergence events could be because of human factors like super spreading events or because of viral factors like increased transmissibility. Now, essentially, all of genetic epidemiology is based on this very single concept. Now, added to that, this emergence points or divergence points can also be calculated in time because of the very fact that the virus mutates at a very constant rate. And that's what I will allude to in the next part of my talk. Now, thanks to the pandemic, one of the approaches to do high throughput sequencing was essentially this technique called COVID-seq, which was brought about by the company called Illumina. And we were fortunate because we were one of the first global labs to do a beta testing for this application, and probably the first real life application for this particular assay system. Now, what this assay system means is that you could do anything from around 350 to around 3,000 samples in 24 hours. And that is thankfully to the multiplex reactions and the high throughput library preparations which are available, but not just the experimental part, but also the high throughput analysis approaches, many of which was created in the lab de novo. And this was possible with a bunch of young students in the lab of Dr. Sridhar Sivasabu, my close colleague and collaborator for almost a decade now. Now, what this made possible in India is to do genetic epidemiology at a very, very large scale that was not previously possible. And our earliest pilot experiments in genetic epidemiology encompassed 7 states, which included southern states of Kerala, Tamil Nadu, Andhra, Karnataka, Orissa, Rajasthan, as well as Western UP. Now, this was done as part of a grant to us from CSIR. And this happened sometime mid last year, almost a year, a few months ago. Now, what we really discovered from this early spread of the virus in India is that apart from the major lineages of SARS-CoV-2, which is prevalent across the world, we did have a very distinct and unique lineage, which is pretty much present only in India. And we named this lineage as IA3I, I to signify that it was a predominant lineage in India, and A3I to signify that it was an outgroup of the A3 lineage, which originated in Iran. And as you see here, the major lineages were the A2A, which had the D614G genetic mutation in the spike protein. And of course, what you see also underlined in here are the early sequences from Kerala, which were of individuals who returned from Wuhan. Now, this distinct lineage was quite interesting because it seemed to have arisen from a super spreading event. You could do the timing of the super spreading event, and as it spread across the country, you had different proportions of this virus in different parts of the country. And as you see here, Kerala did not have this particular virus because there were no Keralites who were part of the super spreading event. But of course, this looking at the genetic mutations, we did know that this mutation had, or this virus variant had some disadvantages. And as you see here, over time, that was pretty much eradicated or removed by a much highly spreading A2A variant with D614 genetic mutation. Now, other things that are possible with such kind of large genome sequencing is that you could build haplotype maps, or what we call as molecular contact maps. And this is extremely useful because this could identify not just the origin of an epidemic or an outbreak, but also how it spread across different parts of the country or different parts of the world. Now, as you see here, many of or most of the samples that were sequenced at that point of time were part and parcel of one of the other clusters. And many of these clusters are large super spreader events, either in marketplaces, in marriage halls, in congregations, and so on and so forth, spanning pretty much almost all of the country. And as it spread across different parts of the country, they also retained the genetic makeup, and therefore that made us possible to trace the origin of such outbreaks. Now, of course, coming to Kerala, we did also have such clusters in 3 distinct clusters for the continuity. Let us name it as K1, K2, and K3. And this was very surprising to us because practically all the COVID cases at that point of time were really attributed to expatriates who were returning from abroad. Now, what really surprised us was that none of these 3 clusters had an outgroup which was a European lineage, but rather had sequences which came from very close parts of the country, including neighboring states. Now, this was important because this also validated one of the policies of the Kerala government to put practically all returnees from abroad into an extensive quarantine. So in other words, genomics can also help us not just derive policies, but also validate existing policies. Now, Kerala has also been one of the first states to take this up very early on, probably the first state in the country to have a very systematic genomic surveillance program, which encompassed all the districts involving 12 medical colleges, the state, regional, and public health laboratories, 2 university centers, and 14 district surveillance units, making it not just an attempt to do genomic surveillance, but also a system to act upon the information that has been provided by the genomic surveillance. Of course, you could also learn more about this on the website, and this was funded jointly by the National Health Mission Kerala as well as the CSIR. Now, over the last 8 odd months, we have had a very fruitful collaboration with a very large number of clinicians spanning across the state. And largely, you would see the pandemic progression in the state has been through 3 distinct waves of viruses coming in. And the earliest wave was because of a lineage called B1.560. This is a very unique genetic mutation, which originated in Andhra Pradesh early last year. But of course, it's spread through the southern states, and Kerala was also a part of it. But as you see here, in early January and February, you started seeing alpha, and therefore active case finding and tracing of the alpha variant in the state was sort of implemented through the district surveillance units and the public healthcare system. And as you see here, over the time, alpha had grown to large proportions. And along with alpha, there was a new genetic lineage, which now we call as delta, which was increasing in very large proportions. And that prompted the state to issue a policy of double masking, probably one of the only states in the country to issue a policy of double masking based on evidence. Now, as alpha and delta has got increasing over the months, the statewide lockdown was sort of put together, and together with a policy of augmentation of beds and oxygen supply. And much recently, as we know, Delta has sort of stabilized in the country across different states. And what's really more important is today to look at new additional genetic mutations in the background of Delta, what we call as the Delta plus genetic lineages. We do have such lineages in Kerala, and we have been closely watching them. And one of the real great advantages of such system is that we have been able to do genomics at scale, and to give numbers, almost over 10% of the genomes today available in the country is done in Kerala. And apart from doing genomic surveillance, it could also understand very pertinent clinical observations, like for example, persistent infections, reinfections, reactivations, as well as breakthrough infections. I'll delve not deeply into it, but probably casually glance through these processes. And having a genomic surveillance program also allows us to identify such extremely rare clinical occurrences. And this is from the Government Institute of Medical Sciences, a government organization in Noida near Delhi, where we put an entire group of people on surveillance, healthcare workers on surveillance, where they were tested on RT-PCR irrespective of their symptoms every 15 days. And what we realized is that there are individuals who were asymptomatic, practically having no symptoms, but having recurrent test positivity. And this also seemed to be the first reports of asymptomatic reinfections in global literature. And how do you prove that this is reinfection? By looking at the genomes of the episodes, in this particular case, episode 1 and episode 2, marked as E1 and E2 for the two individuals, I1 and I2. As you see here, the genomic markers or the mutations are distinctly different in episode 1 and episode 2, in these two individuals, sort of suggesting that this is a real reinfection. And a very close clinical correlate to this is another condition called reactivation. That's when an individual would have recurrent RT-PCR positivity with an intervening period of RT-PCR negativity. And this is another case, an extremely rare case, probably the only case of reactivation which has been genetically proven in global literature. A patient on immunosuppression, a child, and 2 RT-PCR which was positive with an intervening period of RT-PCR negative status. And if you look at the genomes of these two episodes, you would see that the genomes are pretty much the same, suggesting that this is a case of reactivation. And the surveillance also threw up the early cases of breakthrough infections. This is the third published report of breakthrough infections globally. 6 healthcare workers early during this pandemic, and this fortunately is from Kerala, where we could use genomic sequencing to understand what are the genomic correlates of early breakthrough infections. Now, as you see here, we also are part of the national program called INSACOG, which involves a large number of states, and we are one of the major institutions in the INSACOG program, providing genomic services as well as analytics. Now, as you see from the chart, the Delta lineage has sort of stabilized over the last few months. And what's really more important at this point in time is to look for additional genetic mutations as Delta converges onto a set of new genetic mutations, what we call as Delta 1, or now it's called as AY1, AY2, and AY3, with very specific spike as well as non-spike mutations as it continues to evolve and sort of arrive at the fitness. And that is also important in a perspective of predicting into the future, because pretty much all the lineages that are variants of concern at this moment in time has arisen to stepwise mutations onto previous lineages which are very prevalent at that point in time. And as the virus continue to evolve and emerge, it largely is going to evolve in increasing the transmissibility or increasing the immune escape, as a lot more people are immunized either by previous infection or by vaccines. So these are the kind of mutations that we are trying to look at. Unfortunately, we do have 2 large databases, probably the only ones of its kind, collecting very systematic quantitative information on immune escape mutations as well as functional variants on SARS-CoV-2 proteins. Now, why is it important to look at genomic surveillance in the future? It's really more important, and I'll sort of suggest that from this particular slide. What you see here is essentially the panel which suggests the waves, or the 2 waves that happened in Maharashtra. And the bottom panel is essentially the genomic sequences that has happened and the proportions of the 2 large genetic lineages in the second wave, early with Alpha and later with Delta. And the bottom panel essentially is the time to the most recent common ancestor, which is a mathematical model to predict when did Delta arise. And what you see here is very surprising, because Delta arose during the previous peak of the epidemic sometime in August. And this is sort of common sense, because mutations arise when there are large number of infections. And while there are small numbers to start with, they traverse the immune system and the landscape of infections in humans to actually arrive at a point in time, or the right point in time where it sort of gets into a wave where it can infect a large number of people. So the intervening periods between two distinct waves is very important, because that's when you get a large diversity of genetic variants and a unique opportunity to identify such emerging genetic variants to prevent an impending peak. And that's essentially why it is important, as we are in the trough of the second wave, to look forward and see how we can sort of identify genetic mutations which could cause the next big wave. And to do that, we also need tools and techniques to do very rapid sequencing. And one of the approaches that we have developed in the lab is to use benchtop sequencers to do extremely rapid sequencing with 24-hour turnaround times, including the reporting to states. We have now piloted it in multiple different states, including Maharashtra and Kerala, and also internationally as part of the WHO Southeast Asia office. And I think I'll stop there and take questions. But before that, let me acknowledge a lot of people who made this possible. A fantastic set of clinical collaborators, which are part of multiple different collaborative networks, fantastic team at IGIB, and also a fantastic collaborator, Dr. Sridhar. And it's not possible without funding at the right time. And most of this funding has come from CSIR, but also from multiple different sources, like the state of Maharashtra, the state of Kerala, and the WHO Southeast Asia office. Thank you very much.
Thank you, Vinod. Thank you for the presentation. And in fact, you have taken us through the importance of genomic surveillance, and also shown some of the important slides which showed reinfection, reactivation, and persistent infection, like breakthrough infection, how it can be utilized as a tool in more than the whole genome sequencing, how we can practically use it in day-to-day surveillance and activities and intervention to tackle this pandemic. And I think if there are any questions, we'll take up 1 or 2 questions. And I acknowledge also the presence of our Pro Vice Chancellor, Dr. C.P. Vijayan sir, and Ariumaran sir is the Dean Faculty of Medicine, and Shaji sir is the Dean Research, and Rajmohan sir is actually behind the whole show. Sir was continuously involving in designing this entire program, and our Honorable Vice Chancellor Mohan sir is still there with us. And if there are any valuable comments, remarks, or questions, we'll take up. And sir, any points to discuss or any comments from the audience? Morning, sir. I'll just see whether there are any questions in the chat box, but I would like to welcome any comments or suggestions or anything to be discussed at this point of time.
I think what is very important is the need to collaborate. All the speakers have clearly shown that whatever they have brought out is a product of collaboration. So we need to set a stage for larger collaboration with like-minded people. I think that's a message which we need to take.
And other point I would like to clarify, this is a continuous session. So we will be taking up questions on COVID-19 variants and their impact. But obviously we are having next sessions on mix and match studies of COVID-19 vaccines, post-COVID challenges, and future COVID-19 and their pandemic. So there are many things, and COVID-19 treatment updates. So all these are coming in the coming sessions. But if there are any questions related to COVID-19 variants and their impact, we will take up. And if there are any comments also, we would be happy to get at this point. Can we do more genomic sequencing so that we can control pandemic more effectively? I think Dr. Gabriel Gonzalez is still with us.
Yes,
I'm still here.
So you have already mentioned it, but maybe you can take up this question. The question is, can we do more genomic sequencing so that we can control pandemic more effectively?
Yes, actually, I think that many of the approaches that have been taken in the other presentations are also good alternatives. For example, focusing only on the RBD is a good way to do it, because that's the one that can be related with the antibodies and the different variants. The presentation that was just the last presentation shows really well how the genome has been analyzed. Another way I would like to suggest is the project we took, that is finding what are the different variants that we are having using this kind of RT-PCR for specific probes, for specific mutants, and then moving those mutants, once that they are identified, to whole genome sequencing. That's kind of strategically finding what can be new and sequencing that. Because again, as it was just mentioned, the number of mutations between two patients can be just a single mutation. The genome is very stable, but when you have that number of cases, then is when mutations start accumulating faster. So screening among them is finding what are the particularly novel mutations.
Okay, thank you. Vinod, anything to add?
Yeah, so my perspective on this is, I mean, it is not really important to do enormous amount of genome sequencing. Of course, I'm not saying that that's not useful, but what I'm trying to say is that it is really more important to synthesize the evidence and act upon the evidence rather than just sequence genomes. And that's essentially the difference that you see in Kerala and how Kerala has used genomic surveillance in comparison with many other states, which is in many ways has done much larger number of sequencing, but not being able to act upon it because of the disconnect between the evidence synthesis and the action upon. And as I rightly stated, the Kerala program is probably one of the unique programs where all three components of them are tied together, which includes the microbiologists who are going to do the RT-PCR and are also going to refer the samples, the genomics and the genomic analysis system, which is in GVN-IAV, and the downstream process of acting upon evidence, which involves the district surveillance officers.
Thank you. And I think Dr. Gabriel has also given us what are the interventions can we do appropriately when we get the report. So we need to act also. So that is also a very important message. And Dr. Shadji sir has already told the need for collaboration and more work on this aspect. And maybe Dr. Gabriel also is willing to extend his support to those who are interested, and maybe university will be able to take up further so that we'll do something more than, because the collaboration with Dr. Vinod and the center is actually done a good thing for us. And RGCB is already with us, and maybe we will have more opportunities to interact and to work together so that we'll have better output with regard to research and as well as implementation of the research that we have been, the knowledge that we have been acquiring. And I'm sure all the speakers, Sarada ma'am has given a best information what is happening in Kerala. Srikumar sir has laid what we should be knowing about it. And Dr. Gabriel and Dr. Vinod, how it can be utilized more appropriately and can be made clinically useful. And also with the MV Pillai sir given us a broader outlook on the whole series, what we are going to learn, what we are going to acquire over the coming 5 days. And I've done my duty. I think I must thank Mohanan sir, our Honorable Vice Chancellor, Vijayan sir, Honorable Pro Vice Chancellor, Shaji sir, and Harikumaran sir is here. And I'm seeing I was just looking, Rajmohan sir.
Madam, Rajmohan sir couldn't hold on. He has a very unstable internet connection.
Okay. Sir is here. Sir is here. Thank you so much, sir. Sir was doing a lot of work behind this stage. And I'm happy that MV Pillai sir join us together with us for the entire session. I thank you, sir, for being with us. And thank you for our international speaker, Dr. Gabriel Gonzalez. Your presence and your presentation has made the day, which has given a good start for the entire program. Thank you so much. And Dr. Vinod is always with us, and we don't consider him as an external faculty because we always ask and interact with him so frequently. And thank you, Srikumar sir. And thank you so much, Sarada ma'am, for giving us a very good start. And over to Mohan sir and Rajmohan sir, that I think whether we should conclude or if you would like to add any more remarks. Thank you, sir.
Madam, Dr. Suva has raised a hand.
Yeah, madam, please. Sorry, I didn't see. Madam, please unmute, madam. Some,
I'm not able. Okay. Hello. Yes. I just wanted to thank profusely and wanted to say a comment that how much we have learned, because as has been said here, everybody is talking about virus, everybody is talking about variants, everybody even public is also talking about genetic sequencing. But in this session, actually I would like to say that the the webinar series has started in the right way, because putting everything into perspective, that is what has happened here. And you could have a very good idea about the virus and all those things which just Chandni had just said. That I'm not going to repeat it, but it was a very interesting session. And even though we were behind schedule and all that, nobody I think would have known that. So I think so people will be just looking at the watches right now to see that. So it was a very interesting session, and congratulate everybody behind that, and very well moderated by Dr. Chandni. Thank you. That's what I wanted to say.
Thank you, Dr. Chandni. Thank you, Dr. Chandni, for moderating this session exceptionally well. And all the speakers, starting from our great leader, Dr. M.V. Pillai, who gave a clear start of the 5-day program, and then Gabriel Gonzalez, Vinod Skaria, Dr. Srigumar, and Dr. Sharada Devi. All of you have enlightened us and definitely given a lot of ideas for the university. Now it is the job of university and our own faculty to follow what the path shown by you. And this is the day 1, and we have 4 more days following. And I thank each and every one of you. So enlightening talks. Thank you. Thank you so much. University really indebted to you all. Thank you.
Thank you, sir.
Shall we wind up, sir?
Can we conclude, sir?
Yeah.
Sure, we can stop.
Okay.
Yeah. Okay.
Hope to see you all tomorrow.
Thank you.
Thank you, Mr. Harilal too. Thank you so
Thank you
much.
so much for the opportunity. Take care.
Thank you.